Hi, everybody.
Hi, Mary.
Thank you. I'm so glad that you could join all of us here tonight. And I feel honored to be able to give you some introductions and logistical information. And the first thing I'd like to say is that we do have refreshments. And please feel free to get up and down as you wish to the refreshment table while our group is discussing healthcare and other issues. And if you need a restroom, there are 2 restrooms through those double doors, one on either side, one on the right and one on the left. And also, please feel free to sit or stand according to your level of comfort or what works for you. And so what I'd like to do is welcome you to this forum that is not just about healthcare. And as we all know, healthcare is a human right, but we also have a lot of other human rights that don't always get met. And we have lots of partners here in the room today who want to address human rights issues because, if we think of a person as a wagon wheel that can go rolling along through life and avoid ruts and that sort of thing, they need to, all the spokes on that wheel need to be in place. So all of our human rights, each one of them is a spoke on that wheel. And without one or more of them, the person's life is not going to be a dignified life. The wheel isn't going to roll. It depends whether it can be environmental, it can be health, it can be social, it can be faith, it can be any number of needs that create a life of dignity for all of us. In an effort to make sure that we in Vermont get the wheels rolling and allow people to lead dignified life and enjoy their human rights, we've asked lots of our partners to be with us here tonight. And before we get down to sort of brass tacks about healthcare issues, I would love to have each of our partners introduce themselves and their organizations. And so I'm going to first turn to the Turning Point Club of Bennington and ask if Joan will introduce the Turning Point Club. Oh, all right, I'm sorry. Never mind. No, wait, we'll come back to Joan. I apologize. I can't see well, so I really need to have eye care in my health package, which I don't. But no, I'm sorry, it won't work. So instead, we're going to go to the Vermont Center for Independent Living, VCIL, and they're going to tell you a little bit about what they do and how they fit into the human rights perspective.
Hi, I'm Lynn. Vermont Center for Independent Living is a grassroots cross-disability organization founded in 1979. Our mission is to empower Vermonters and promote an active citizenship by working with others to create services that support self-determination and full participation in community life. We are people with disabilities working together for dignity, independence, and human rights. When we hear that rental assistance vouchers will be scaled back for our peers with mental health struggles, or that fuel assistance funding will be significantly reduced, and the promise of the pathway to universal health care is no more, we need to speak up. All of us, including our peers with disabilities, need the basic human rights to have a decent life. We need adequate housing, nutrition, and health care. We encourage and support our peers to take charge of their lives, to speak up, and to let the decision makers know the ill effects of their decisions. We advocate at VCIL for inclusion in society and our local communities, to be able to live with dignity and to be able to live with no shame. Austerity and broken promises will not work, and it's time for the people to lead.
Thank you. Thank you, VCIL. And now I would like to turn to the Turning Point Club, and Joan will explain some of the really crucial human needs that are filled by their organization.
Very, very much. Hi, everyone. Do you hear me? I don't really need this, probably.
But anyway, I'm very happy to be here tonight, and in all honesty, I could say about our folks everything that she just said, because people who struggle with addictions, they are people who just, society is not really very fond of them when they're in their addiction. When they try to turn their lives around, it's an uphill battle, but it can happen. And what Turning Point offers is a very safe place for people who are trying to turn it around to be with other people in recovery. And in all honesty, it's a peer-to-peer organization. And the other thing is that people think that we are affiliated with the 12-step programs. Many of us love the 12-step programs, and a lot of us have our own connection with them. But the 12-step programs rent space from us, basically, so that they can have some meetings there. We have many, many new programs that we're putting together. We have recently added a addiction and families. And that's an educational 3-week program that we started, 3-session over 3 weeks, that we started as a result of people saying, what do I do? You know, my son this, my husband that, my father, what do we do? And it has been well received, and people are really, really enjoying it. I could go on and give you a whole bunch of list of things like that. I could be up here for half an hour. Are you kidding me? Forget the 2 minutes. But anyway, I invite you over to the table, and one of the things that we have is what we call our menu of recovery. And it lists everything that we have without elaborating. It just has what it is. People who are struggling with recovery are like everybody else who are trying to recover from something. This is an illness, it's a family disease, and they deserve the support that they can get to make it. I love recovery. I'm a recovery family member, and I happen to love addicts, which is my thing. But anyway, so I invite all of you, please stop over to Turning Point sometime and let us show you what we actually have there. We are not like we used to be. We're all cleaned up, we're fresh, we're bright. We got wonderful, wonderful folks that do the volunteering there. And please stop over and see us anytime. Okay? Thank you.
Thank you. And we would also like to hear, and I hope it strikes everybody, including those of you who will be listening at home on CAT TV. Welcome to you as well. I hope it strikes everybody that we're hearing a lot of the same things about human needs, human dignity, and now we're going to hear another aspect of human rights, and we're going to hear it from Selena, who is here representing Gano and Migrant Justice.
Okay. So Ghana's is a student group at Bennington College. At this point, we're about 10 people, and we work in the southern Vermont area, work a lot with the Free Clinic with Sue Andrews, work with the Vermont Workers Center, and yes, I can talk louder, I'm sorry. And then getting tutors on local farms to do ESL teaching. So recently, in January and February, we started working with Migrant Justice, which is an immigrant rights group based in Burlington, has been around for a couple years now, I think 3 years. And they have recently launched a new campaign called Milk with Dignity. And they're working to get corporations that benefit from low milk prices to retroactively pay a premium back to the farmers and farm workers so that they can have quality housing and fair wages. So we're here representing Migrant Justice and also talking a little bit about what we do as our little student group based out of the college, and hoping to get you to sign on to the pledge for buying milk that is a fair price, that is produced with dignity, and if you're willing to volunteer and help getting farm workers to different events or help promote the campaign or interpret or anything like that, if you have language skills, we would love to get you involved. So please stop by and ask us any questions that you have.
Thank you, Selena. And of course, one of our real innovators in the Bennington community is the Bennington Free Clinic, which is all about giving people the health care that they need. And so I would like to introduce Sue Andrews from the Bennington Free Clinic, and she can tell you a bit about that partner organization.
Thank you. So I work for a little tiny organization called Greater Bennington Interfaith Community Services. We also call ourselves GBICS. And we run the free clinic as well as the local food and fuel fund and the kitchen cupboard food distribution program. So the clinic was started in 2009 to help meet the needs of adults in Bennington County who didn't have access to medical care because of lack of insurance. In the time that we've been open, we've kind of grown in a number of different ways. In addition to providing primary health care and access to referral care, we have begun for the last several years signing people up for the Affordable Care Act and the insurances that are available through that program. Another program we've added is screening, brief intervention, and referral to treatment for people who are using and abusing substances. And the other thing I want to mention is we also have an interest in dental care. And I'm going to put in a pitch right now for the free dental day that's coming up on Saturday, April 25th. It's being held at the 2 Harwood Drive, the Oral Surgical Associates, from 8 until 3 in the afternoon. I just wanted to say a little points about our role in helping people sign up for health care. I'm somebody who thinks that the Affordable Care Act has had a positive impact, although we certainly have a long way to go. At the end of open enrollment in February of this year, we know that there's about 1,680 people remaining in Bennington County who don't have health insurance, and we actually know quite a bit about them. Most of them, 2/3 of them, are single young men who are eligible for Medicaid. The unfortunate thing about single young men is they don't come in for health care until they do something like cut their finger off. So it's a matter of tracking them down and helping to get them on. Since we opened in 2009, we've assisted several thousand people to enroll in health insurance. And we've seen the rate of uninsured adults go from 8% in 2009 to just over 4% now, which is a little bit higher than the state average of 3.8% uninsured. So that's the good news, that that's several thousand people who have access to care that they didn't have previously. A challenge in Bennington has been the fact that there has not been primary care practices taking patients for quite a long time until in the last year. The Arlington Family Practice turned into a federally qualified health center, so that's kind of relieved the pressure locally, but access is difficult if you have to drive to Arlington and if you don't have good transportation. So that's we've got some improvements, but still some challenges. And as you all know, Vermont Health Connect has not been without its problems. I just wanted to put in a pitch for the fact that I think one of the best things that they did with the Vermont Health Connect was to establish the Navigator program, which is a program in which there's folks who are trained to assist consumers to sign up for health insurance. We have a team of 9 navigators at the clinic, and we've signed up over 600 people in the last 18 months. And then finally, out-of-pocket deductibles remain a barrier to healthcare, especially for people who elect bronze plans. And then a couple of things that don't come up too often, but I think are really big issues that we need to address going forward. One is consumer literacy about how to use your health insurance. Many people buy it, then they have it, but they don't have a clue what to do with it. And we need to do more in this area. And then the final thing is consumer responsibility for healthy lifestyles remains a challenge. And we need to change our emphasis from curing problems to promoting health.
Thank you, Sue. And now we would like to hear from, and last but certainly not least, the Vermont Workers Center, who started the Healthcare as a Human Right campaign and who is holding this particular forum in the knowledge that health insurance is not health care. They're two different things. And I would like to turn the mic over to Charlie Murphy from the Vermont Workers Center and VCIL to talk about the Workers Center.
Good evening. My name is Charlie Murphy, as Mariette said. I am a volunteer with the Vermont Workers Center. I became involved about 6 years ago when the Healthcare is a Human Right campaign came to Bennington. The Vermont Workers Center has been around for 15 plus years, going on 20 years, as I recall. It started off as a grassroots workers' rights organization, and over the years they've realized that there needs to be more to get people into a decent way of, or decent lifestyle, decent more than just having a living wage. So they created the Healthcare is a Human Right campaign because they realized that the way the healthcare system is right now, it's in Vermont compared to other states, it's good, but it needs to be a lot better. And so tonight we're here to talk about what we have and what could be. So the Vermont Workers Center has several campaigns, one of them being Healthcare is a Human Right, another one being the People's Budget, and then people and putting people in the planet first, among others. The Workers Center has collaborated and partnered with other organizations, as Mary had said, as we pointed out today, with for the Vermont Center for Independent Living, and in other parts of the state, Green Mountain South Advocates, Vermont State Employees Association, and Vermont Early Educators United. I'm part of our local organizing committee, and there's a core group of us that try to organize and bring people into our fold, so that we can organize events like this to bring people together and try to educate people on the need to speak up and be part of a movement toward a better life here in the state of Vermont. And also, before I step away, I just want to say that on May 1st, there's a May Day rally. It's the 6th or 7th one, and it's in Montpelier, and we're working on bringing people up from Bennington to Montpelier for that rally, where we will speak out, as Lynn had mentioned in the description of what Vermont Center for Independent Living does, about the needs of people in Vermont, people who don't have a voice other than being able to group together and speak as one in numbers. So that's what I have to say.
And so with that set of introductions, and with much appreciation for everyone here in the room, I would like to introduce Lee Russ, who is going to lead us in a discussion and some observations about the idea that what we now call, what most people call Obamacare, and which Sue correctly referred to as the Affordable Care Act, same thing, but still insurance, how that differs and could differ from Green Mountain Care, which is the health reform that we all worked so hard for several years, to have a public good healthcare system, actual healthcare system, that's also publicly financed. So with that, I'll turn this over to you, Lee.
Okay. I really don't speak very loudly, so if you can hear me, just raise your hand or shout out. The basis of what we're going to do here is 8 slides that ask a question, and 8 slides that have at least one answer to that question. And it's all based on the idea that an awful lot of information about our current healthcare system is learned and heard by the people in the public only sporadically, and this is an attempt to put a few pieces of it together to give people a much better idea of where we really are. And the last 2 questions are very broad. The first one just being, what have we learned about our healthcare system by the time we get to the 7th question? And the 8th being, how could or would Green Mountain Care work so that people have a chance to compare the 2 of them? I just want to start by saying that American healthcare is regarded around most of the world as something like a crazy quilt. We have Medicare, we have Medicaid, we have private commercial insurance, we have private commercial insurance obtained through employment, we have private commercial insurance obtained through the exchanges under the Affordable Care Act. We also have, most people don't think about it, but we also have TRICARE, the military health care program. Over 9 million people are on that. The Veterans Health Administration, which strangely enough is not the same as TRICARE. And the Veterans Health Administration claims to serve another 8.76 million. There's the Federal Employees Health Benefits Program, which says it covers 8.2 million people. And before we get started on the slides, if you don't mind, anybody here on Medicare other than me? Lots of Medicare people. Anybody here on Medicaid? Several people on Medicaid, including some that were also on Medicare. How many people get their insurance through their employment? Anyone? A few people. And how many people have a health savings account? Just out of curiosity. Okay, just for comparison, I'm on Medicare. I also have a Medicare supplement policy, which if you're on Medicare, you know you pretty much need. I have another commercial policy for prescription drug coverage through Medicare. My wife is on a commercial insurance policy through the exchange, which is pretty heavily subsidized by the state. And we have the remains of a health savings account from days when we were younger and more affluent. That's an awful lot of stuff for two people living in a small town to have as their health care. So, as Sue mentioned, Obamacare, or the Affordable Care Act, I only call it Obamacare not as an insult, only because that's the way most people have come to think of it. But as she mentioned, it has done some very good things. One of them is to expand Medicaid. Last year, my wife was on expanded Medicaid. It has also made it possible for a lot of people to get commercial insurance with some subsidies from the federal government. But again, I believe, as Sue also mentioned, an awful lot of people that buy commercial insurance through the exchange, especially if they're on the bronze plans, end up having insurance but not having access to care because of the deductibles and the copays. So before we get started on this, I think we should just basically review what the Affordable Care Act is. That's the federal law that was passed, I'm not sure when, a couple of years ago. It's what set up the exchanges. It's what gives us the subsidies if your income is low enough. Green Mountain Care was intended to be a publicly financed universal health care program, which essentially means that instead of paying for care when you go to the doctor, you pay for your care all during the year through taxes on your income, taxes on whatever the state decides to tax in order to fund the program. When you go to the doctor, you don't have a deductible, at least in the ideal world. You would not have a deductible, you would not have a copay. You would take your card, you would go to the doctor, you would get your care, you would give the doctor the card, and again, in a perfect world, the doctor would be reimbursed at a sufficient level that they don't go broke caring for patients who happen to be in Vermont. So, hit the first slide. Okay, so what is the relationship between Green Mountain Care and the Affordable Care Act? We just basically covered that, but in more detail, hit number 2. Okay, obviously GMC is not the same as the Affordable Care Act, which is something that opponents of Green Mountain Care kind of deliberately fudged when they were fighting Green Mountain Care. They tried to get people to think about how much trouble they'd had at the exchanges and somehow get them to think that because there were troubles with the exchanges that this meant that Green Mountain Care was going to be a disaster. Since they're totally different things, that really doesn't make a lot of sense. At a more detailed level, the Affordable Care Act still requires that you buy commercial insurance. GMC would replace commercial insurance entirely, at least one version of it. Exactly what it would be still remains open. Obamacare involves different insurance options with varying premiums, deductibles, and copays, whereas GMC could provide comprehensive benefits without going through that. Obamacare ties access to care to wealth to some degree, because if you have money and you have a big income or you have assets, you can buy yourself a much better insurance policy. The complexity involved with Obamacare, which Sue touched on to some degree in terms of the problems with the exchange. If you think about the exchange, Why was it so complicated? It was complicated because they were trying to coordinate your income with your available subsidies from the federal government, your selection of an array of commercial insurance policies, and that's an awful lot of information to be coordinating for a simple thing like getting health care. And again, as Sue has already told you, Obamacare does still leave some people unable to afford health care. There are some people who don't have health care coverage at all, and there are many more people who have coverage but really can't afford to use it because of the co-pays and premiums. I'm sorry, co-pays and the deductibles. Which brings us to question 2. Just out of curiosity, just to see what people know about the current system, I'm assuming that everybody who's on Medicare kind of knows the answer to this, so if anybody who's not on Medicare wants to take a shot at this, feel free. What is the minimum amount that a person on Medicare would have to pay in order to have Medicare coverage for hospitals and doctors? It's multiple choice. A, nothing, because you've already paid for it during your life as a worker. B, $100 a year. C, $600 a year. D, $1,200 a year. Or E, $2,400 a year. Anybody who's not on Medicare want to take a crack at that?
Yeah, not on Medicare.
Or on Medicare, I don't care. E? You're absolutely right. In fact, E is kind of an underestimate. In all likelihood, you would end up paying closer to $3,000. I believe I'm paying $3,100. But go ahead and hit the next slide. It's based on the fact that you have to pay $1,200 a year minimum for Part B coverage. Part A is free, Part B is not. So you're paying $1,200 a year roughly for Part B coverage, higher than that if you have a high income. In order to get a supplement policy, it's going to cost you, in all likelihood, another $1,200 or more. And prescription drug coverage, at least in my case, is another $350 or $400 on top of that. Hit the next slide. So a real good question before you start talking about what should we change, how should we change it, and how important is it to change, is how much are we spending now? Does anybody want to take a real rough guess on that? No, for the entire state, how much money is being spent on health care these days? Anybody want to take a rough guess? $2 billion, $4 billion, $6 billion? Pick one of those. Yeah, okay, hit the button. The last report that I was able to find, which I believe is from 2014, was $5.9 billion. And if you can read the small print down there, for a population of 625,000, which is roughly what Vermont has, that works out to $9,489 for every living soul in the state of Vermont. Hit the next slide. Okay, one of the reasons for that, or one of the possible reasons for that, comes from this question here. According to a 2011 Commonwealth Fund study, the support staff in Ontario, Canada doctors' offices spent 2.5 hours a week per doctor on administrative tasks related to health benefits. What was the comparable time spent by the same people in American practices? About 4 hours, about 8 hours, about 20 hours, or about 32? Anybody willing to take a guess? Yeah, come on, there's no penalty. Okay, hit the next one. 20.6 hours per physician.
Per week.
Per week, compared to 2.5 hours. That's an 820% increase. And I think that might say something about why healthcare costs so much more in America than it does in Canada, and probably some other things which I shouldn't say on camera with a microphone. Hit the next slide. And I was just, this is almost a personal interest question for me. I was just really interested in this. When you sign up through the exchange and you get a subsidized premium, you're basing that on your estimate for what your income is going to be for the whole rest of the year. So what happens if you get to the end of the year and you underestimate it? Your income is actually higher than what you told the people on the exchange when you got your policy. Does anybody know what happens? No. There's no fine, but you do, by God, have to pay it back. Hit the next screen. The subsidy overpayment has to be paid back. If your final income was more than 400% of the poverty line, you have to pay back the entire overpayment. If your final income was less than 400% of the poverty line, you pay back some of it based on that little chart, which is probably too small for you to read. But even when you're paying back money because you've been over-subsidized, it's complicated. They don't just say, pay it back. I'm sorry. You have a question, or are you just blocking out the sun? Okay.
Sorry about the sun.
No, underestimated. You said I'm going to earn, you said, for example, when you signed up on the exchange, I expect to earn $24,000. You actually earn $32,000.
You overestimated your income.
Underestimated it.
I'm sorry, overestimated. You're right. You're right.
Yeah, underestimating is not a problem. You can get your additional subsidy at the end of the year. It's when you underestimate your income, you're going through the entire year, and this is obviously applying to people that don't have a lot of money. If they did, they wouldn't be getting the heavy subsidy for their premiums. So at the end of the year, somebody that does not have a lot of money ends up owing the IRS funds based on having underestimated their income. At the bottom there, if you can't pay back the full amount of the overpayment, you can set up an installment plan. Doesn't that sound like fun? If you do that, you remain in debt to the IRS until the full amount is paid. But even though you're in debt to the IRS for the coming year, you're still eligible for another subsidy for your insurance for that year, and you get back on the am I underestimating or overestimating roulette table. Hit the next slide. Very similar question. What happens if you were placed on Medicaid based on your estimated income, but your actual income for the year makes you ineligible for Medicaid? How does that work? Anybody want to take a guess on that? Did they come and take back the care? Did they make you sick again if you were treated? Hit the next slide. This one gets really, truly crazy. I don't know what the answer is. I talked to the people at the Department of Vermont Health Access, and the answer I got was literally there in quotes. Medicaid eligibility is determined on a monthly basis. The yearly income is not relevant to the monthly eligibility. However, Medicaid customers are required to call and report any significant life changes, including changes to income and household size, within 10 days to Vermont Health Connect. Which left me with the question that I still haven't gotten an answer to. How does that work? I mean, if it's based on a monthly income and your monthly income varies, what does that mean? On January, you're eligible for Medicaid. In February, you get extra money that you didn't have in January, so you're ineligible. Now you have to go on the exchange and buy a commercial policy. But then in March, your income goes back down and you're back on Medicaid for a month? I mean, this is truly strange. I don't know the answer to that. Okay, so this brings us to the two questions where hopefully we actually are going to have some discussion, which is based on what we've just talked about in questions 1 through 6. What would you say that tells us about our existing healthcare system? Yeah, I think James had it right. Words not needed. Hit the next slide. What it told me, and feel free to chime in if you disagree with any of these or if you think I left off something important. the basic answer to me is we need a newer, simpler, sustainable system, because this one is A, more complicated than it needs to be, B, more complicated than anyone could possibly understand, C, needlessly running up costs because of the complexity, D, more expensive than we can possibly sustain over the long run, E, driving up the cost of almost every job performed by people, including state and local government. Sometimes people overlook the fact that the town, state, and county employees all have health benefits. The more the health benefits cost, the higher our taxes. The expansion of Medicaid, I fully applaud that. I think that was by far the best aspect of Obamacare. But at the same time, that's Medicaid. Somebody's paying for that in taxes. The people who got put on expanded Medicaid, frequently you go from thinking, that's great, finally I have coverage, to what doctors are taking Medicaid patients. And as Dr. Dundas can probably tell you far better than me, the reimbursement you get for treating a Medicaid patient really doesn't pay you for your time. If you have a high percentage of Medicaid patients, you're probably going to end up going out of business. It also means if you forget about just the dollar costs, it also means that access to care remains a question of wealth and luck. Some folks get health care, some folks don't. Some folks get all of it that they need, and again, some folks don't. Some folks can relax, and some never ever get to, because they're constantly worried about whether they can afford to go to the doctor, what's going to happen if they lose their job, what's going to happen if they lose overtime that they've been getting. It's not a very calm life when you're living on the margin. So the last one, and there is no hard and fast answer to this, is how would Green Mountain Care work in practice, and how would that compare to what we have now? What I did, this is basically just to make myself happy so you don't have to like it. I just made up what could be a Green Mountain Care card. If we ever actually implemented Green Mountain Care in its best form, where people don't have deductibles and co-pays, everything's paid for during the course of the year based on your income and other things that you're paying taxes on. And what would it look like? Well, it could look like this. The Vermont medical card telling you it's Green Mountain Care, gives you a card number. The MCR, in an ideal world, what you would have is literally, when a provider provides care, they take that card, everybody has one, they run that card through the payment machine. It goes through a central office, and that central office immediately reimburses the provider, and then figures out where the actual money comes from. Is this a person that's entitled to Medicare? Then Medicare is going to pay part of it, and Green Mountain Care will pick up the rest. Is this a person that's entitled to Medicaid? If so, Medicaid will pick up part of it, maybe Green Mountain Care will pick up another part. But you would have just that one card. This is pretty much the way it works in Canada. It's what they call the sun card, I believe. It has a picture of the sun on it, it's kind of yellow. And you pick up your card, and you go get care, and as long as it's one of the treatments and types of care covered by the system, which is most of them, that's it. You don't have to worry about whether you've met the deductible. You don't have to worry about what the copay is. You don't have to worry about whether the doctor is going to accept you as a patient based on who's paying for it. And I don't mean to badmouth the doctors, because frankly, I think the primary care doctors in this state are in big trouble. As more and more people are on Medicaid, it's just getting worse. Hit the next one. So as I said, there is no single answer. The considerations would include how GMC could and should work in terms of its fit with other healthcare systems. And again, in my opinion, the ideal is that Green Mountain Care simply becomes the immediate payer and then gets reimbursed by any other system that is obligated to contribute. Go back to that, no, not you. Go back to the slide about the 20-point-something hours of administrative tasks paying for health care, compared to the 2.5. in Ontario. Why do you think that is? I mean, in large part, that's the difference. In Ontario, there's a card, you submit the card, there's none of the messing around with the little details and the complications. And here, messing around with details and complications is pretty much what we specialize in, because it's a crazy quilt. As I said, what I would imagine is that every Vermont resident gets a GMC card. The subscriber number would be unique to the subscriber and include a code which would alert the Central Reimbursement Office if the subscriber was also on another plan like Medicare or Medicaid or TRICARE or the Federal Employee Benefit Plan. When a provider bills, the GMC card is run through the computer. The Central Processing Office pays the provider, and the computer automatically picks up the right of GMC to be reimbursed from the other plan. That reimbursement request would be automatically filled out with the requisite information and sent to the other plan. Everybody would be carrying the same kind of card. Every provider would have to bill only one entity, the GMC. All bills to other plans would be handled by the GMC central office. So just as a closing question, how much do you think that would reduce overall administrative costs? I would say a lot. That's all I have for you. The slideshow has come to a sad end. Yeah.
Can't see you anymore because of the sun behind you.
Did you have a question, or are you just shielding your eyes?
Another fact is in line with administrative costs per doctor is that in Mass General there are 300 employees taking care of the insurance, billing and receiving, whereas in Toronto General, which is a similar sized hospital, there are 3 employees.
Yeah, there is a speech by a Professor Mayoni, I can't remember her first name, who's very big in the Canadian healthcare system. And she gave a talk at Johnson State College either last year or the year before. And she said one of the things that really struck her when she came down and was taking a tour of the Plattsburgh Hospital, Plattsburgh, New York, not a big town. She was walking through the hospital and realized that this huge area, which she described as taking up almost an entire wing of the hospital, was devoted to billing. And she was just blown away because she teaches, I believe, in Montreal, it could be Toronto. And her hospital, which is many, many times larger than the Plattsburgh Hospital, has, as she put it, 3 desks. You know, it's a serious thing. Yeah.
There's one thing to keep in mind with all of this going back and forth between the States and Canada, and that is that their taxes are a heck of a lot higher than ours are to take care of this healthcare system that they have. I have relatives in New Brunswick, and they pay a lot more when they do get to the doctor for whatever procedure it is, except for births, but that may have changed even because that was like 30, 40 years ago when I first had that info. But and they also wait a long time, as they do, for instance, in England. So, I mean, there are pluses and minuses to both sides. I don't know how we would ever come to that kind of a situation in the U.S.
How we would get there, that's part of what we're doing right now.
But it's taxes, and who's going to scream about that?
Yeah, I would really have to see where you got that information from. My impression is that that's not really true.
I'll give you my relative's phone number, you can call them, whether it's a eye operation or a birth or a broken leg. So.
Yeah, feel free.
I just wanted to add here that we actually have a gentleman that works with our organizing committee who's from Canada, and in fact, his son actually helped set up the exchange in several provinces. And he says that that just isn't the case anymore about people. And he's not the only one. There are a number of Canadians that have said, you know, there are these rumors going around. And yes, we do pay high taxes, but if you look at what we pay in taxes compared to what you pay, compared to the $5.9 billion that it's costing, it's a lot of difference. And if you look at France, for example, pays less than half of what we do, and they have universal health care. So I just want-
Just two quick things, and I'll get to Sue. The first one is, even if that turned out to be true, and as I said, I don't think it is. I
It may
think,
not be anymore, but it was.
but even if it is, that kind of still leaves out the whole idea of the human cost. And two, I got really tired of hearing Canadian scare stories. So I wrote this for Vermont Digger. You are welcome to a copy of it. And anybody else who would like one, I'll be happy to give it to them. Sue?
I just wanted to comment that it always concerns me when I hear people talking about the queuing in Canada and the UK, because we have it right here.
Oh, yeah.
You know, we are not those entities, but have you tried to get a psychiatrist in Bennington County?
Is there one?
Is there one? Exactly.
Is there a need for one?
Have you tried getting access to primary health care in the town of Bennington if you have certain kinds of insurance? I mean, we already have these issues, so I don't think that we should be put off by those stories, because I think by leveling the playing field and adjusting the payment system, incentivizing people to become primary care physicians or be primary care providers, we could really see a change in the way things play out.
Yeah, one thing to keep in mind is that whatever Canada is, nobody's saying adopt Canada whole cloth. Canada's had their system for an awful long time. If we have anything even remotely like it, that could serve as a very good model both for what to do and what not to do. So just because they do have a problem there, assuming that it's a problem, doesn't mean that we would have to incorporate it here. Dick?
I just wanted to say that on average, each American pays about $8,000 in healthcare costs per year, and each Canadian pays about $4,500. The idea that their system of healthcare itself is worse than ours is just not true. There are, if you have a heart attack in Canada, you're treated as well as you are in the United States. If you break your leg, you're treated well. If the people that are in the so-called queue to get care are the people that need elective surgery, for example, getting a hip replaced. And that has been a long time coming, the need for that hip replacement. It's not an urgent thing, and therefore you can't really count that as a significant negative against the Canadian healthcare system.
Yeah. Michael?
Yes, the Vermont Veterans Home is experiencing difficulties. They just got funded, but with the stipulation that by 2018, they've got to be pretty much self-funding. I didn't know this, but just about everybody who works on there, except for the union people, are almost volunteers. You know, the people who run the Veterans Home, the board and all those, there's a lot of people that contribute their time and energy to making that place the way it is. But they are going to experience an enormous influx as the people who fought the Gulf Wars become aged. And they're really not prepared for that any place in the United States. We spend trillions of dollars sending our boys and girls out, and then we hold back the purse strings when they come back and they have post-traumatic stress disorder or something that is not, you know, like a broken arm that you can just fix and send them on their way. Our attitude towards people as commodities to be used and bought and sold, you know, it smacks of, you know, slavery, basically. You get a job and you can't quit because if you do, you'll lose your health benefits. You get a job and it gives you excellent benefits, but you don't make that much and your public assistance goes away. So there's a whole bunch of I guess I call it unintended consequences of good legislation. And the problem is that we have a system that's based upon insurance rather than care. And I think that's the emphasis that has to be done. Mary, you talked about a needs assessment. Find out what the people need. My guess is that after a few years of taking care of the people, it'll be less expensive to take care of healthy people than it will be to take care of sick people.
Yeah.
And that's where you're gonna get your savings. You're
Well,
gonna have
I think you get your savings in a bunch of places.
in a
That's
bunch
one
of
of them.
places. That's just one of the places you're gonna get
Yeah.
your savings, is if you take care of people who can't earn money, but yet have vital roles as grandmas or unofficial babysitters, or keeps the family going by cooking when everybody else is working. That's important too.
Well, it's sort of related to that. I'm not sure how many people stay up with what's going on in the federal legislative world, but the majority in the House has proposed a budget that would make Medicaid a block grant program. And if you follow politics, you know what that means down the road. That means they're going to give a set amount of money. They're not going to raise it in all likelihood as time goes on. And the states eventually start cutting back, less benefits, less reimbursement, hurting primary care doctors even more. And the same budget is recommending that people who I believe the age is 56 or 57, anybody 56, 57 or younger, will not get the Medicare that we know. They will get Medicare as a voucher system. And again, if you agree with me about what that means long-term, that means the voucher doesn't increase from year to year and your care just continues to go down the tubes. So it's a national problem, but what we're talking about here tonight is an attempted state solution for at least our state. So, yeah.
We have had long experience with the Medicare program.
Mm-hmm.
And the last numbers I heard were that its administrative costs were something like 3 or 4%.
Very low.
And the private insurance companies' costs were something anywhere between 18 and 30%, which included administration and advertising and
Profit.
that sort of thing. And so if you just look at that, it makes no sense to spread out healthcare among all of those different entities, which are all for profit.
Okay.
And then we have longer experience, not as much, but with Medicare D than we do with Obamacare. And I have never seen those kinds of statistics on that program. But that again relied on private insurance. It's very complicated. Nobody understands it. But it's got to cost more than it should if it were the same sort of model as primary Medicare.
Well, actually, my understanding, and if somebody here probably knows, so if I'm wrong, tell me. My understanding is that the premiums on the Part D are subsidized. They're subsidized.
I don't think all of them are.
No, not all.
No?
Some of them are.
Subsidized by
Yes, by what?
Well, if they're subsidized at all, I would imagine it's by the federal government.
But not all of them are. And it's correct that the insurance industries, they actually spend millions of dollars lobbying
That's where the
for
money goes.
that program because they make a lot of money off
All right, I've got a plan
That's the
B,
difference.
Yep,
prescription drug, isn't that what that is?
yep, that's what we're talking about.
Well, when I was in Maryland, it only cost me $7.40. I come to Vermont, she says, well, if you're gonna live here in Vermont, it's gonna cost you $18.50. I said, a lot. Well, the price has gone up. We contract every year, we contract with Medicare.
Yeah, I got a Part D.
So it was 15 in Vermont, and now it's gone to 18,
Yeah.
plus change. And I thought, well, what's the difference between Vermont and Maryland? There's less people here,
You
or are
would,
we sicker?
you would have to ask the insurance company, and they're not likely to tell you.
I would imagine a bigger population will share the cost better than a
So
smaller
they're
population. population.
They're paying in more.
Efficiency in numbers.
Yeah. And I also think that Vermont has a very old population.
Economy
Huge population.
is Vermont's
Well, I didn't think 1850 was bad, but
Yeah. Well, wait till next year, it won't be
it's
1850.
better than not having any.
Yeah.
Well, that kind of makes me, and correct me if I'm wrong, Sue, but I have worked as a navigator with the free clinic as a volunteer. And I've observed that the expansion of Medicaid, which I support 100%, is based on income only. But for those individuals that have Medicare, you're required to do the paper application because this computer model can't figure everything right. So you do a paper application and you are required to list your assets, resources, et cetera, not just your income. You're treated differently. And if I'm wrong, correct me please, but that's my observation of the two different, why is Medicaid, regular Medicaid, income only? If I walk in off the street, I'm income only, I qualify for Medicaid. But because I have Medicare, if I go in again and I'm a person with Medicare, and I do this paper application, and X, Y, and Z is on there, then my application is treated differently, and I'm not eligible for Medicaid. So,
I'm sorry, I just want to say, for the Medicaid application, they do ask for your assets.
Not for expanded Medicaid.
No.
Not for the expanded.
Income
No.
only.
They do not.
It's income-based only.
They don't want you to sell your.
Now, again, if you, right, we had a $2,000 savings limit for an individual, a $3,000 savings limit for a couple, and there's another Medicaid program that maybe people aren't aware of, that the working persons with disabilities, they have a $5,000 for an individual and a $6,000 for a couple savings limit. So there's other eligibility criteria, is what my point is. And I'm not begrudging anyone that became Medicaid eligible because of the expansion. I think that's wonderful. But I do feel that it's unfortunate that the other individuals have to be subjected to a different criteria to access Medicaid.
Yeah, there's really no attempt that I can tell to coordinate the 100 different programs. None. That's why you've got Medicaid is based on your monthly income. Subsidies on the exchange is based on your annual income. What happens if your monthly income goes up? Are you now eligible because of your annual? It's crazy.
My daughter has experienced that exact thing. She was Medicaid eligible, and then because of earnings, had to do the exchange and buy a plan, and 2 months later, she's Medicaid eligible again.
Yeah, you want to talk about administrative expenses? Good grief. James?
I have a question that Mary brought up to me, and Tracy, I want to aim this to you. She said, though I have a very low copay, because my father's benefit, I'm on my dad's, because I was born with I don't know if it was brain damage or what, but they called it back in the 60s, a lazy baby, meaning I was slow. All right, to get to the point I'm trying to get at, Mary said if I'm on Medicaid or receive Medicaid, I shouldn't have co-pays on Part D.
Well,
Remember you said that?
I think what I said was that a lot of people don't have co-pays when they're on Medicaid and Medicare.
Yeah, that's what I meant. I'm sorry.
No, that's all right.
All right.
But that doesn't have anything to do with Plan D. Plan D is different.
Right.
But that's what I'm talking about, Plan D. I mean, it's real minimum. But my point is, when Mary made the point that she knew several people that didn't have co-pays, and I do, Mary said, then you don't get Medicaid if you are paying a co-pay under Part D. You don't get Medicaid. Remember you said that?
Well, I think we were trying to figure out whether you got Medicaid or Medicare, and that's how that.
That's very confusing for anybody.
All of it is.
No, I know, but I'm
It
just.
is, oh, believe me. It's
I
not-
know.
I still don't know the difference.
Peter?
Yes, my situation is I have to pay a certain number of co-pays to reach a minimum, and then my co-pay goes to zero.
Oh.
Yeah. And then, when you meet that, right at the end of the year. You gotta start all over again.
Yeah, which I just got in the beginning of the year, boom, we're back up again.
You shielding your eyes, or you want to say something?
I was going to say something. I've also noticed that when working with families or being a parent myself, that for those of us who are lucky enough to maybe have unearned income of such as like child support or something like that, that's also been a variable for families as well, to where many families, if they collect any type of child support, often it's on a monthly basis, and if they don't get it, it's actually computed in your system annually if it's a court contract and saying you're supposed to get this much a month. So if you don't get it, it's still like you're supposed to get it. So legally they still track it. So what happens is if that partner chooses to give you money, doesn't choose to give you money, it's still as if you're getting that money, and then you're kind of screwed at the end anyway. And when they do, like, so let's say the arrears come in all at once, then that month, the same thing, you've made all of this, so then it completely bumps you off the program completely, and you have to start back over again as well. So there are I hear the different spectrums of ages, and just want to give sort of a totality of the various different situations that families are facing too when they're in this situation as well.
What I would point out is that all of these problems are because we have these basically silly requirements. If your eligibility for a program or coverage is based on your income, is based on your age, is based on your employment, you're always going to run into this. Always. It goes without saying. If, on the other hand, everybody has a Green Mountain Care card, and your coverage or your eligibility, your care, whatever you want to call it, is based on the fact that you live in Vermont, you don't have any need whatsoever for all these complications. You just don't. I hear the same thing from people who talk about, oh my God, what's going to happen? There's so much cheating, so much fraud on Medicaid and Medicare. What's going to happen when the whole program is like that? Well, what are they going to cheat about? It's an uncheatable system. If you live here, you're on it.
What happens if you're visiting and you get sick here, or you're a migrant worker and you need help?
Well, you just heard that.
Mary wants to answer that. There's any number of answers to that, but Mary.
There are any number of answers. In terms of being a migrant worker, it's based on residency, not citizenship, and that's another major difference. So that you would have a Green Mountain Care card, whether you're a citizen or not. And in terms of injury, it depends on how the system is set up. But I want to tell you a story that someone told me about, and it's actually, I won't share the person's name but anyway, they were skiing in France and broke their leg. And the person could have afforded to pay for their medical care over there. So they went to the hospital, they got the leg fixed, everything's all good. They went back to see the doctor, they wanted to know where they paid the bill, and they said, "What's bill? Where's your billing department?" "We don't have a billing department." It freaked this person out. This was only a few years ago. It freaked them out because, now theoretically, what some countries might do is they might say, well, if you have insurance, we'll try and bill them, but it's probably not worth their administrative hassle to get that money back. And this is just a really clear example to me of how having everyone have actual medical care, not insurance that they may or may not be able to use, two different things, makes a big difference in people's lives.
Wow.
Anybody else? Yeah.
I'm wondering, in a universal care system, would the government have more power to negotiate lower prescription costs from pharmaceutical companies? This has recently come to my attention in a big way. And I'm wondering, between the two systems, how would the pharmaceutical industry be handled, so to speak?
I think you're gonna have shareholders in that picture too, well, as far as the healthcare companies.
Yeah, it basically, it depends on the terms of the program that you set up, but certainly that's one of the things that you could do, and that's one of the things that could actually help bring costs down.
And that most countries do.
Yeah, most countries do that, and I don't know how many people are aware of it, but in America, we essentially subsidize the drug purchases in other countries because they're paying lower costs. The drug companies want their profit to show up in whatever country they're going to have to pay the lowest taxes in. So what they do is they charge an awful lot to America because we don't have the bargaining power to keep the price down. But they use their ability to affect the price when they transact between subsidiaries. So like if they're selling a pill from subsidiary A to subsidiary B, they can price that pill at $25 or they could price it at $6. If they price it at $25, they're not going to have a lot of profit here. They'll have a lot of profit where subsidiary A is.
It's similar to the difference, a country that's doing what they call global purchasing, which is what you're talking about, where the country purchases all of what they need, whether it's hospital equipment, whether it's pharmaceuticals, whatever, from a pharmaceutical company, has a lot more leverage, as Lee is saying. It's kind of like if I go to a Sam's Club or a BJ's to buy something in volume, I can get things so much cheaper than going to the local price chopper. And it's that same principle.
I just want to point out that Mary is more easily heard without a microphone than I am with one. Yeah.
I'm just curious about this universal care. It's wonderful. If you go to the doctors, is it their and you need, say, your shoulder might have to be replaced? Is it that one doctor that can say that, or is this going to have to go through a couple or three doctors to say that? Well, I don't know if he does need one, or I don't know if he doesn't need one. It's something like that, or a knee, or anything.
Yeah, the basic standard that almost all of these systems use is medical necessity. The system will pay for anything that's medically necessary.
Okay.
I don't think the system has any incentive to run you through 5 doctors.
Okay.
You know? So I would imagine, again, it all depends on what the terms of the program are. But in all likelihood, a primary care doctor who can document in any reasonable way that you need that procedure, that should be all you need.
It's not like insurance companies that try to keep you.
Michael?
Yeah, I'm going to definitely need a knee replacement. And in the meantime, I got a knee brace. And that works out really well. But just because I can get a less costly knee replacement doesn't mean that I want to go out and get my knee replaced next year or even the year after. I'm going to take every step I prudently can as a responsible citizen to preserve and lengthen the durability of the knees I got before I got to replace them. I don't know if anybody wants to get a quadruple heart bypass before they actually suffer an angina attack or a heart attack. It's just not one of those things. Now,
Yeah, I think the whole...
I ski, and at any time I could probably injure myself. I'm lucky. I seem to bounce back when I fall. But
well, that's going to change as you get older.
That's a risk that you take. And just because I will get some subsidized health care if I hurt myself, I don't go out of my way to hurt myself.
No, I think that idea that the opponents of universal care keep floating is just clearly nonsense.
Right.
I mean, it's just nonsense.
I'm doing better because I don't have to worry about whether if I get sick. You know, I had whatever the intestinal things going around. I didn't go to the emergency room. I knew what I had, and I knew if it didn't get better in a couple of days, I'd do something about it.
The only people that like going to doctors are hypochondriacs. They're going to go whether they have coverage or not because it's up here they have to go. But for the vast majority of people, nobody's going to the doctor just because it isn't going to cost you anything.
And that it's funny that you mentioned that, because last year, and Kathy and Sheila were probably there too, up at the steakhouse, we were talking to a bunch of representatives, not ours, by the way, and talking about Act 48 and universal health care. And they said, well, they keep telling us, though, that if people can just go to the doctor whenever they want, they're going to go all the time. And we looked at them and we said, if you had a day off and you could choose anything to do, would it be go to the doctor? And they said, well, no. Well, then why would everybody else always want to do it? But it seems to be an effective argument, so I would like to encourage each of us who are here tonight, when we hear that argument, to say exactly what you said, Michael. Why would you want a heart bypass before you need it? Why would I want to go to the doctor for fun?
For attention.
Once you're healthy, what do you need to do? And if we get the people healthy, at least as healthy as they're capable of being, I mean, there's some people who will never be able to ski no matter how many doctors they see. Dick?
I forgot what I was going to say, but
You want to say something else?
I was going to say the process with universal health care would be basically the same as what we have now, because you have a primary care doctor, you tell him you have a bad knee or a bad shoulder, and he sends you to he might order an x-ray to look at that, and then he might send you to the orthopedic surgeon.
Right.
So that's what we do now. And so that's not, a panel of doctors don't have to decide whether or not you need surgery.
Not even a death panel?
But actually, currently, what does happen is the insurance companies actually do that.
Yeah.
And I actually just had that experience where I had to get an MRI on my arm, and it was taking a long time for them to schedule the appointment. And so when I called my doctor, they said, your insurance company hasn't approved it. And so when I called them, they said, well, your doctor hasn't approved it. We went back and forth, back and forth, back and forth, and I put them both on a three-way and said, you all duke it out, because I'm the patient, I'm the one who needs the care now, and this is going back and forth, and what they told me, we figured it out, but what they told me was that there's actually a panel of people who are medical and insurance. Some of them have, these insurance companies, they'll have medical providers on these insurance companies' panels, and they will determine, based on what your doctor has said, whether they feel what the doctor's ordering is viable in this situation. So even though your doctor says you might need the necessary care that you have right now, you might be being blocked for that care because the insurance doesn't feel you actually really need it. And that almost actually just happened to me 2 weeks ago.
That's exactly right, and every doctor has probably one or two nurses or clerks that whose job it is to interact with the insurance company on behalf of the doctor.
That's part of that 20.6 hours.
That's exactly right.
Yep.
And talk about overhead expenses for doctors. It's a wonder that all of the doctors don't quit, because we're just burdened by so many administrative hassles that it's hard to get it right. We have people waiting on the line, on the phone line, on hold for half an hour or an hour waiting to get your case approved by the insurance company.
Yeah.
But that does not happen with Medicare. If you have Medicare, it does now happen with Vermont Medicaid, by the way. But if you have Medicare, the Medicare system does not put doctors through that hassle or put patients through that hassle.
I think that might be because Medicaid is actually administered through insurance companies.
Exactly.
Yeah, whereas
Yeah.
Medicare.
I mean, I have what I think is one of the ultimate absurdity stories. I had a double hernia. You know that you tend to wait a while in Bennington to get surgery for something like that. So I had about 6-week wait. And they approved 2 trusses. I'm sorry, they approved 1 truss. I wanted 2 because, you know, sometimes you have to clean that first one. and it was a pretty bad double hernia. I believe it took somewhere between 10 to 15 hours of time from me, my wife, and the pharmacist. God knows how much from the people on the staff at Blue Cross Blue Shield. And they finally, after weeks of talking and calling back and being on hold, they finally approved it. You know how much it cost? $28 each. Per. Yeah. Yeah, that's crazy. Well, we're getting towards 20 to 8, so unless people have some other serious questions, I did want to throw one thing in which I forgot during the slide presentation. We were expecting to have somebody who's a pretty severe critic of Green Mountain Care here tonight, but they didn't show up. And this was my response to that person, but even though he's not here, I'll give it to the camera. As far as I know, of all the studies that have been done about Green Mountain Care and what it costs, I don't recall there being a single study that said that it wasn't economically feasible, that it would cost more than the current system. I've never seen that. When Governor Shumlin backed off and said this is not the time to pursue Green Mountain Care, if you read what he said, he never once said that it was because it was too expensive. Not one time. And not one time because it was too expensive. He said it was because it was the wrong time, too disruptive. It was basically a political decision, saying that I don't have the political environment to enact a tax of this percentage. But had you enacted it, the total cost of Green Mountain Care would have been lower than what we're paying now. And I don't know of a single study that contradicts that. So if anybody knows, speak up now.
Green Mountain Care is,
That would be
anybody can get on that, the one that's here now.
The what? No.
No.
We're not talking about the Green Mountain Care.
All right, the Green Mountain Care that Lee and that we're referring to here is, well, it's not, it's more than that actually, but it's up to us as the people that live in Vermont. Because back in 2011, our state enacted a law that said that by 2017, we should have universal care called Green Mountain Care. And that would be not an insurance, not the insurance companies, but that it had to be health care as a public good that was publicly financed. The governor has decided that that he's not doing that anymore. He doesn't just get to decide that a law is invalid. I mean, we are the ones that enacted that law, and we are the ones that need to say, we don't really care much what you want, Governor, because what we want to do is make sure that the law is followed here. And there are several financing plans out there so Green Mountain Care, what we're talking about tonight, is the system where you would have a card, you would go to the doctor, and the doctor would get paid, and you would get health care. Oh, okay, you're right, it is. So that's very confusing. And actually, I have to say, this is just my opinion in wrapping up, that I do believe that a lot of the opponents of having a very simplified universal care system have actually used some tactics to make everybody think. A lot of people in Vermont think, but we already have health care, and look, it's not working because the insurance companies aren't. That's not what we're talking about, so thank you for bringing that up today. And I know we're going to close, but I want to thank everybody. And I also want to say that we're concerned about health care as a human right. We're concerned about the dignity of people in their everyday lives, whether it's health or work or whatever their situation might be. And on May Day, many of us are coming together in Montpelier to march for health and dignity, and so that we can have dignified lives. And I just want to say a short story to everybody, tell a short story about when I was at the UN arguing for universal health care. And some of you have heard this before, but we had bus passes from the hotel, but other people were buying their bus tickets every day. There's never anybody that asks for your bus ticket on the bus, right? You get on the bus, nobody asks. So after about 6 days of this, I actually said to the woman next to me, do they ever check people's bus tickets? And she said, once in a while, maybe once a year. I said, but people buy their bus tickets every day. And she looked at me and she said, how would we have a bus if we didn't buy bus tickets? So if you talk about financing human needs through public financing, that's the kind of paradigm shift or attitude shift that we care about each other. We're a community of human beings. We need to take care of each other. We can help take care of each other by having forums like this, by going to the May Day rally, and by letting our elected officials know what we think about this. So I want to thank everybody for coming. And before you leave, please take a May Day flyer, and please feel free to have some more refreshments and to visit all of our community partners before you leave.
If anybody